We will start lecture and it will be split into two parts. First part will be dedicated to the nuclear imaging of the hepatobiliary system, taking into consideration that nuclear imaging of this system currently we're using less often compared to the urinary tract. We will stop less on the hepatobiliary and spend more time on a urinary tract system. So let's start our lecture. Nuclear imaging in the biliary tract disorder, and we will start talking about the different diseases. And the first, it's acute cholecystitis, syndrome of right upper quadrant pain, fever, and leukocytosis that is associated with gallbladder inflammation that is usually related to gallstone disease. In pathogenesis, very important role plays cystic duct obstruction, and clinical presentation is characterized by the prolonged, it means more than 4 to 6 hours, steady, severe right upper quadrant or epigastric pain, fever, abdominal guarding, a positive Murphy's sign, and leukocytosis. The nuclear imaging plays additional role in diagnostics of this disease. We call this method holoscintigraphy, and it's indicated in diagnosis if diagnosis remain uncertain following ultrasonography. The conditions that can cause false positive results despite a non-obstructive cystic duct include severe liver disease, which may lead to abnormal uptake and excretion of the tracer, fasting patients receiving total parenteral nutrition in whom the gallbladder is already minimally full due to a prolonged lack of stimulation, biliary sphincterectomy, which may result in low resistance to bile flow, leading to preferential excretion of the tracer into the duodenum without filling of the gallbladder. Here on this slide we can see the nuclear scan, the dynamic scintigraphy from the upper part of upper rows. We can see beginning of the examination under the number of 3 and the last scanning under the number 14. This is an example of normal technetium 99M hepatic immunodeacetic acid called HIDA scan, and it shows early filling of the gallbladder at 15 minutes. We marked it with the white arrow, and complete filling by 25th minute. Here you can see it, white arrowhead indicating patient cystic duct. Here you can see this bright region, it's a gallbladder, and this darker region, but still gray, this is outline of the liver. Another example of the HIDA scan in patient with acute cholecystitis. The hepatic HIDA scan is abnormal and shows absence of filling of the gallbladder. You can see it here, yes, abnormal filling, indicating obstruction of the cystic duct. The duodenum starts to fill with the isotopes at about 20th minute. You can see white arrowhead, and the radioisotopes flows directly to the duodenum. The gallbladder never fills during the course of the 6-minute examination. These findings are consistent with the diagnosis of acute cholecystitis. Here you can see the filling of duodenum. Acalculous cholecystitis accounts for approximately 10% of all cases of acute cholecystitis and is associated with a high morbidity and mortality rates. typically seen in patients who are hospitalized and critically ill. A calculus cholecystitis should be considered in patients who are critically ill or injured and have a clinical picture or sepsis or jaundice without a clear source. It should be considered in patients with a postoperative jaundice. In stable patients in whom the diagnosis is uncertain, after ultrasonography, a scan using technetium labeled hepatic immunodiacetic acid HIDA may be useful. Here we can see the risk factors for acute calculus cholecystitis, a lot of them. I will not stop on every factor. Functional gallbladder disorders in adults. Biliary pain resulting from a primary gallbladder motility disturbance in absence of gallstones, sludge, microlithiasis, or microcystal disease should be considered in patients with a typical biliary type pain who have had other causes for the pain excluded. The prevalence of functional gallbladder disorders among patients with biliary type pain and a normal transabdominal gallbladder ultrasound is up to 8% in men and 21% in women. If we talk about the clinical manifestation, we talk about presence of the biliary type pain, also known as biliary colic. You know, we got renal colic, and this is biliary colic. Their liver and pancreas blood tests are normal, no gallstones or bladder sludge as seen on imaging, and upper endoscopic examination are normal. Biliary colic is usually constant and not colicky. Intense discomfort located in the right upper quadrant or epigastrium that may radiate to back, particularly to the right shoulder blade. The pain is often associated with the diaphoresis, nausea, and vomiting. The pain lotus is less than an hour, ranging from moderate to excruciating in severity. Develops 1 to 2 hours after ingestion of a fatty meal. An association with meal is not universal, and is a significant proportion of patients. The pain is nocturnal, means appears at night, with a peak of occurrence around midnight. After an attack, the physical examination is usually normal. If we talk about the diagnosis of this disease, we must say that functional gallbladder disorder is a diagnosis of exclusion in patients with the typical biliary type pain. The first step in the evaluation of such patients is to exclude other causes for the patient's pain. If no other causes are identified, patients should undergo cholecystokinin stimulated cholecystography to confirm the diagnosis, nuclear method of examination. Let's talk about the cholecystography, which allows us to calculate the bladder ejection fraction of bile, which is low in patients with a functional gallbladder disorder and is less than 40%. Helps predict which patients are likely to respond to surgical treatment. Cholecystectomy should only be performed in patients with the typical biliary symptoms. It should be not ordered for typical symptoms such as bloating, fullness, or dyspeptic symptoms, as these patients are unlikely to respond to surgery even in the presence of the low ejection fraction. Here we will describe the method of this nuclear examination. Following an overnight fast, radiotracer is given as intravenous bolus. The radio-labeled tracer is excreted in the bile, and if the cystic duct is patent, it will flow into gallbladder. After 45 to 80 minutes, baseline radioactivity from the region of the gallbladder is measured. After 30-60 minutes infusion of syncolite, then another measurement of gallbladder, stimulation. We perform stimulation here. Alternatively, fatty meal with a 20-gram fat is used, alternative to the syncolite stimulation. The potential disadvantage of the fatty meal stimulation is that gallbladder emptying has to be monitored for a minimal minimum for 60 minutes following the meal because of a longer latent period in comparison with the chemical infusion, chemical stimulation. Here on this slide, we can see a graph, the quantitative HIDA. This is a great example of the functional method of the nuclear imaging called radiography. We do not see image, we do not see liver or gallbladder, we just see a graph which shows us the percentage of remaining radiopharmaceutical and time scale. So on this slide we can see quantitative HIDA that shows early filling of the gallbladder and at 25th minute. Here we can see it. At 57th minute, here we can see infusion of the CCK was initiated, a broad white arrow, stimulation. Mild reduction of the gallbladder activity was demonstrated. The ejection fraction was 30% and normal is the at least 40% of or greater. Here we can see the scanography of the liver, the nuclear scan. In the 60-minute anterior view, there is an overlap of the gallbladder, common duct, and duodenum. Here we can see anterior view, and they little bit overlap. Here, the left anterior oblique projection view separates the structures and makes accurate calculation possible. Here we can see gallbladder, here we can see duodenum and common duct. On this slide, we present the patient that had a chronic recurrent right upper quadrant pain with normal ultrasonography. The 60-minute study not shown. This slide was normal with visualization of the gallbladder and normal biliary to bowel transit. On this image, we can see sequential images every 5 minutes for 25 minutes after injection of the CCK stimulation. Shows no contraction of the gallbladder, no difference. On this slide, we can see the example of the cystic duct remnant. It's a 40-year-old man with a history of 15 years of post-cholecystectomy, and he had symptoms of the intermittent right upper quadrant pain and fatty food intolerance. Ultrasound was technically suboptimal due to the patient's obesity and excessive bowel gas. The common bile duct measured 9 millimeters. The nuclear imaging was performed using TC99M. Radiopharmaceutical was the SIDA study, which demonstrated normal hepatic uptake, clearance, and biliary to bowel tract transit time. However, the persistent focus of activity is identified anterolateral to the mid portion of the common bile duct, consistent with the cystic duct remnant. We can see it marked with the arrows here and here. This is lateral view, and this is anterior view. Anterior, and lateral view. Very common pathology, it's a sphincter of Oddi dysfunction, SOD, encompasses both sphincter Oddi stenosis and sphincter Oddi dyskinesia. SOD has been associated with 2 clinical syndromes, biliary pain and idiopathic recurrent acute pancreatitis. 2 or more attacks of well-documented acute pancreatitis of uncertain cause despite an exhaustive workup. It means no laboratory or non-invasive imaging features of the pancreatitis, with complete resolution of clinical and laboratory findings between attacks. Here on this slide, we can see the anatomical presentation of the region of the common bile duct. Here we can see the pancreas, pancreatic duct, sphincter of pancreatic duct, sphincter of common bile duct, and sphincter ampulla, major ampulla, and here you can see duodenum wall. This is the audiosphincter and ampulla of Vater. This disease is most commonly recognized in patients who have undergone cholecystectomy, hence the name of the post-cholecystectomy syndrome. May be related to unmasking of pre-existing SOD due to removal of the gallbladder, which may have served as a reservoir to accommodate increased pressure in the biliary system occurring during the sphincter spasm. Diagnostic workup. Only patients fulfilling the Rome 3 criteria, you will read about them in books, should undergo invasive evaluation for SOD, like liver tests, transaminases, alkaline phosphatase, bilirubin, and pancreatic enzymes like amylase, lipase should be checked. Structural abnormalities need to be excluded by means of the transabdominal ultrasound. Quantitative cholecystography. This is nuclear imaging using TC99M. Labeled dyes can provide a standardized semi-quantitative assessment of delayed biliary drainage in patients whose gallbladder is absent. Criteria used for diagnosis are the time to peak, the half time of excretion, the duodenal appearance time, the helium of duodenum transit time. Some studies use a stimulation with CCK, but may use simple cholecystography. Here on this slide, we can see an example of the cholecystography, and here we can see accumulation, background accumulation at 10 minutes in the liver. We can see the excretion of the radiopharmaceutical through the bile ducts directly to the duodenum. It's shown on this slide. On this slide, we can see another example of the only functional method of the imaging of the nuclear imaging of the bile ducts. It's a cholecystography, radiography, yeah. And on these figures, we can see different cholecystographical indices like Tmax, time to maximal accumulation of radiopharmaceutical, time to peak activity. What means activity? Maximal radioactivity measured over the region of the duodenum or Hepar or gallbladder. These are unified indices. This is the time activity curve. This is scale of the radioactivity over the organ, means activity. The higher the number, the higher is radioactivity of the organ, means the better accumulation of the radiopharmaceutical in this region. And this is scale of the time in the minutes from 0 to more than 90 minutes. And here we can see the process of accumulation of a radiopharmaceutical. Here we can see the vascular phase. Here we can see the parenchymal phase, maximal peak, and the slope of the excretion of the radiopharmaceutical. T half-life of T 1 second, half time of excretion. And another example, very similar. This is helium time activity curve, TAC, and this is duodenum with a dashed line, shows us the duodenum radioactivity over the duodenum. Very clearly we can see that with excretion of radiopharmaceutical from the helium of the duodenum, we can see with decreasement of this curve, with the excretion of radioactive bile into the duodenum, increasement of the duodenum curve. And you can see how the bile is coming to duodenum with so-called waves with such a frequency, which illustrate the peristalsis. This is an example of the patient that had a recurrent abdominal pain 1 year after the surgery, cholecystectomy, and cholecystography is consistent with the partial common bile duct obstruction. Note the diffusely dilated intrahepatic ducts, dilated common hepatic and common bile duct with the apparent cutoff at the distant sphincter of Oddi. Here we can see dilation here and cutoff. This is some biliary to bowel transit seen on the last image. Here we can see it, gray curve. And localized duodenal activity is noted inferior to the common duct. We will make a short break. Now this short break will reconnect and we will continue talking about the nuclear imaging of the urinary tract. The second part of the lecture is dedicated to the nuclear imaging of the urinary system. In case of urinary system pathology, the application of the nuclear imaging is relatively often. Radionuclide studies of the urinary system, classified as in vivo and in vitro, in frames of in vivo nuclear imaging of the urinary tract, we will talk about such main methods as the rhinography, it's only functional method of examination, scintigraphy, single photon emission computed tomography, SPECT, positron emission computed tomography, PAT, and hybrid modalities at the SPECT-CT, PET-CT, and PET-MRI. And in vitro nuclear imaging examination, we will explain on an example of the prostate-specific antigen. So let's start talking about the radionuclide rhinography. Here on this slide, you can see an example of the radionuclide rhinography. If you listened carefully to the previous part of the lecture, you will remember that this functional method of examination, this is only functional method of examination, we don't see organ, we only may assess its function. This is vertical scale, the accumulation of radiopharmaceutical, this radioactive substance in the organ. So this activity means radioactivity over the kidney, and this is time scale from 0 to almost 30 minutes, shows to us the accumulation of the radiopharmaceutical and its excretion. So let's talk about this method. This method we're using for the study of kidneys function using radiopharmaceuticals, means chemical drugs, which consists of radioactive molecule of isotope and special formula of the drug, which is administered intravenously. This method allows to determine the function of each kidney, to assess the status of glomerular filtration rate, GFR, and tubular secretion. The rate of excretion of radionuclide from the kidney can also be judged on the status of the urinary tract. It is used for the detection of kidney disease, as well as the study of the dynamics of the pathological process, monitoring the effectiveness of the medical or surgical treatment. It is the most sensitive method of assessment of kidney function, especially in the early stage of the development of the pathological process. It has the advantage over radiographic methods because it allows to quantify the functional state of the kidneys at low radiation load, which is very important. There are no absolute contraindications, but is not prescribed to pregnant and lactating mothers. Investigations are performed by means of a clinical radiograph, we call it direct rhinography, or a gamma camera equipped with an electronic computing device, computed rhinography, in patients sitting or lying position. As the radiopharmaceutical used filter kidney glomeruli, we got such a long name for this radiopharmaceutical, is the ethylene, triamino pentaacetate, labeled with the isotope TC99M, or secreted renal tubules. We use hyperate labeled with the iodine 131. So you must remember that we may assess the function of the kidneys separately. It means assess glomerular filtration rate using TC99M and secretion secretion of renal tubules using iodine 131. In the course of the study, there is a continuous graphic recording of the content of radiopharmaceutical in each kidney, as it's shown on this figure. In the presence of technical capabilities, in addition to the renograms, get a curve characterizing the cleansing of the tissues of the body from the radiopharmaceutical drug. We call it clearance, as well as the curve reflecting the flow of the drug into the urinary bladder. So usually we place 3 radiometers, kind of a probe, over the right kidney, second probe over the left kidney, third probe sometimes over the urinary bladder, and usually fourth probe over the heart to assess the radioactivity in blood and compare the clearance of blood from the radiopharmaceutical, means assessment of the kidney's function. On this slide, we can see the renogram, the presentation of the study, nuclear study, which shows to us 2 scales. This is radioactivity over the kidney, this is graph of the kidney, and time in minutes. We got 3 main phases of this radiographic curve. The initial stage lasts approximately 3 minutes, 2-3 minutes. This is vascular curve. The radiopharmaceutical via the renal arteries from aorta, from the bloodstream, comes to the kidney and start to be filtrated from the blood by the renal parenchyma. And this process is occurred during the second phase. We call it concentration or parenchymal phase or secretory phase, and it lasts approximately 4, maybe 5 minutes, 3, 4, 5 minutes, up to the peak of radioactivity of accumulation of radiopharmaceutical in the kidney's parenchyma. After that, the urine, which consists radioactive isotope, will be excreted from the kidneys into the calici, and then to the pelvis of the kidney, then to the ureter, and then into the urinary bladder. And we call this phase excretion phase. This is third phase, and it's the longest, and the slope is less sharp. Here we can see the indices, different indices. We will calculate top maximal activity time, and this is half-life time of excretion of radiopharmaceutical from the kidney. It occurs on from 8 to 12 minutes. And this is the second curve. Actually, it's a fourth curve, if we will count. This is cardial or heart curve. We can see that right after this is 0, right after the intravenous injection of radiopharmaceutical, its concentration, means radioactivity, in blood will be at maximal level over the heart. Yes, we will measure over the heart the maximal radioactivity. During the process of the filtration by kidney of radiopharmaceutical from blood, we will see how this curve decreases up to the minimal value. It means that the kidney filtrates radiopharmaceutical from blood very well. The kidney's function is good. Here on this slide, we can see normal and abnormal types of the radiographic curves. You must remember them. Here we can see again the normal presentation of the kidneys, right and left kidneys radiographic curve. And here we can see the abnormality, like this is a isosthenic curve observed in the case of the chronic renal disease, renal insufficiency. We can see almost absence of the second and third phase. The kidney is not secreting, not filtrating the radiopharmaceutical, not accumulating it. B, it's obstructive type of the curve, which consists of first phase, second phase, and no third phase at all, because there is a stone, for instance, in the upper urinary pathway, for example, upper part of the ureter, which obstructs the urinary pathway, and the radioactive urine cannot be excreted from the kidney, result in such type of the curve. Here we can see the parenchymal type of the curve, which is B, which shows to us decreased level of the curve and prolonged time of excretion, no such sharp peak, which is, shows to us decreased function of the kidney. The renal parenchyma cannot secrete this radiopharmaceutical as it should be, and it's very characteristic to the parenchymal diseases like inflammation of the kidneys, like pyelonephritis and glomerulonephritis. And also we can see here another type of the curve, it called reflux curve. It means that it got normal first, second phase, and during the third excretory phase, the radioactive urine, which is passing from the upper urinary pathway to lower urinary pathway to urinary bladder, will be refluxed, comes back to the kidney, to the upper part of the ureter, which is reflected in the increasement of the curve, and there could be multiple such increasement. And the last, it's non-functioning type of the curve, which is actually not presented here because it actually will show us no increasement of the curve, which is the same as the ISO line, which reflects no function of the kidney, which could be observed in two cases. First case, it's a total absence of the kidney's parenchyma, in case, for instance, of the terminal last stage hydronephrosis, or in case of absence of the kidney, when the kidney is absent. Here on this slide, again, we can see the pairs of the scintigraphic presentation. This is morphofunctional imaging of the kidneys, right kidney, left kidney. And we can see the graphical presentation of the radiopharmaceutical. From here we can see the solid line, it's one kidney, dashed line, the second kidney, and we can see that this is, as you may guess, the obstructive type of the curve. In both cases, from both sides, we can see the obstruction, maybe due to stone disease, we cannot say it's precisely, or due to the stricture, or due to the cancer, due to the tuberculosis, bilateral, or of the ureters, or due to the hormones disease, which is retroperitoneal fibrosis. So in this case, we can see bilateral obstructive curves telling us about the presence of obstruction. On this part of the slide, we can see the obstructive type of the curve. Again, in both cases, the dashed line shows us more obstructed kidney. Probably this is the this kidney. Yeah, we don't see the passing of the radiopharmaceutical into the ureter at all, and this solid line corresponds with this kidney, which is also obstructed because we can see the radiopharmaceutical passed only to this level, yes, to the middle of the ureter, and it's also obstructive type of the curve. Kidney scintigraphy, usually performed with a TC99M DMSA, dimercaptosuccinate acetate, is by far the main method of assessment of the morphofunctional status of the kidneys in the world practice of nuclear medicine. This technique is most informative in detection of areas of tissue, renal tissue sclerosis, in urinary tract infections, in evaluating the effectiveness of antibacterial therapy, predicting the course of the disease and the possible development of the chronic renal insufficiency, chronic renal disease. Here on this slide, we can see the process of the stage of the scintigraphy of the kidneys, the dynamic scintigraphy of the kidneys, because we may also use static scintigraphy of the kidney, which is presented in only one image, and dynamic scintigraphy of the kidneys performed during a period of a time. Here we can see the laboratory, the bed, the gamma camera with two crystal detectors, which are placed over the human body, can rotate around the human body, the technician, the monitor, and after the injection of radiopharmaceutical intravenously, we perform scanning. Here we can see the patient's body, actual transverse cut, slice, which emits gamma waves. We can see gamma waves, which are emitted by the TC99M, an isotope which is radioactive. They emit outside and can be captured by this gamma camera head. This is gamma camera head, which consists of the scintillation crystals, photomultiplier tubes. The sodium iodine scintillation crystal emits light as it contacts with the gamma radiation, and this light will be captured by the photomultiplier tubes, and after that the signal will be transformed into the electric signal, conversion to electric signal, sent to the computer analysis, and the reconstruction of the image, this is static and this is dynamic scintigraphy, will be achieved. Here you can see the anatomy, normal kidneys, ureters, urinary bladder, the right kidney usually lower than the left kidney. Here you can see the inverted images. This is right side, this is left side, ureters, urinary bladder filling, yes, and we can see the accumulation of radiopharmaceutical. The advantage of the DMSA scintigraphy in contrast to dynamic studies is the ease of implementation and the difficulty of interpreting the results. It should be noted that DMSA scintigraphy in no case denies the conduct of functional studies, but should be used in a complex of methods of examination of the patient with the pathology of the urinary system. For this purpose, it is necessary to know the diagnostic possibilities of different methods and to apply them according to the algorithms for one or another nosological form, depending on the tasks of the study, the stage of the disease, and the stage of examination of the patient. Radiologists should actively prescribe additional radionuclide studies to complete the examination of the patient and to obtain sufficient information of the extent of kidney's disease. Now we will make a short pause because we got limitation on time on the Zoom, and then please reconnect and we will continue. Indications for the DMSA scintigraphy are acute and chronic pyelonephritis, urinary tract infections, anomalies of kidney development, hydronephrotic transformation of the kidney, reflux nephropathy, juvenile hypertension, and transplanted kidney. The pharmacokinetics of the TC99M DMSA are: DMSA after intravenous administration is excreted from the blood by two exponents. The first exponent 8 minutes by glomerular filtration, and the second within 9 hours accumulation in cells of proximal tubules of the nephron. Approximately 4 to 8% of radiopharmaceutical within the first hour is eliminated by glomeruli of the kidneys. Up to 91% of the radiopharmaceutical is in protein-bound state, resulting in blood being slowly cleared of radiopharmaceutical. From 40 to 50% of the administrative activity is fixed in the kidneys after 2 hours. Therefore, the optimal interval for obtaining images is 2 to 4 hours after injection. TC99M DMSA during this time is also recorded in the liver, spleen, and bone metaphysis of growth, but in lesser amount. The RPL activity is a very important issue. Patients with the renal pathology are in the category DB, and annual allowed exposure dose for them should not exceed 20 millisievert for adults and 10 millisievert for children. It means this category is a patient with a somatic pathology, not with oncologic pathology. We don't usually use this method for the diagnostics of the oncologic pathology. In adults, the activity is 185 megabecquerels, which is 5 millicurie. In children, lesser 1.85 megabecquerels per kilogram, which reflects the radioactivity which is introduced into the patient's body. The minimum activity for children is 15 megabecquerels. The maximum is not more than 110 megabecquerels. When using these activities, the effective radiation dose is in the range of 0.8, 1.2 millisieverts in adults, and 0.6, 0.88 millisieverts in children. Just for your understanding, to compare, for instance, one computed tomography scan without contrast is approximately 235 millisieverts per one scan without contrast. But usually, for instance, in case of the renal pathology, in case of the suspicion of the tumors, we perform multi-phase computed tomography. It means we perform 4 phases: native, corticomedular, parenchymal, and excretory phase, which will result in the total dose of approximately 20, 25, 30 millisieverts, which is in approximately 20, 30 times more than the one nuclear scan of the kidney. So this is very important. Radiation dose on critical organs is also very low. Here on this slide, we can see the normal presentation, normal scintigraphic picture of the kidney. This is posterior projection, this is anterior projection, left and right oblique projection. You must understand how we should interpret the radionuclide, the nuclear scintigraphic picture, the image. The normal accumulation of radiopharmaceutical in a parenchymal organ like a kidney, like a liver, like a thyroid gland, is that in the central part of the organ we got high accumulation of radiopharmaceutical. We call it high fixation or high activity of radiopharmaceutical. It's totally normal. As on this slide, we can see the high intensity colors in the centrum of the organ. It's normal because in the central organ is less thin, it's well vascularized, and to periphery it becomes more thinner, less vascularized. So we can see decreasement of the accumulation, darker colors to the periphery of the organ. It's totally normal picture in case when we use organotrophic radiopharmaceutical. It means that organotrophic radiopharmaceutical will be accumulated in the healthy parenchyma of the organ. If we will use tumorotrophic radiopharmaceutical, which is not shown here, which is not used here, we use it in the thyroid gland pathology. The tumorotrophic radiopharmaceutical will be exclusively accumulated in the malignant tumor, not even benign, but malignant tumor. Here on this slide, we can see organotrophic radiopharmaceutical. It means that it will accumulate normally in high amount in the healthy tissue and in lesser amount or not accumulated at all in the damaged tissue. But we actually cannot say we don't know the cause of this decreased accumulation. We cannot differentiate, is it a benign lesion or is it malignant lesion? It's impossible to say using such a scintigraphic picture, but still we obtain morphofunctional information, information about the size, shape, location, position of the kidneys and their function. This is morphofunctional examination. And here on the lower part of the slide, we can see the different types of the abnormal accumulation. In the central part, we can see both kidneys, and we can see that there is no normal accumulation within the kidney. We can see the places with the decreased accumulation here, 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 here. So we talk about the damage of almost whole kidneys parenchyma. Such abnormal accumulation we call diffusely decreased. So diffusely damage of the renal parenchyma. Usually we observe such a picture in case of the inflammatory kidney diseases like pyelonephritis, like glomerulonephritis, and so on. Damage of the renal function, not in case of the such a local processes like benign tumors, like cancer. No, in this case we don't observe such lesions. In case of the focal lesions, like benign lesions, like cysts, benign cysts, like malignancies, like renal cell carcinoma, we observe local absence of accumulation. We call it local cold nodule, or region of decreased fixation, or region of decreased activity over the organ, and it's presented here in the upper pole of the kidney. There is locally no accumulation of radiopharmaceutical. We suspect focal lesion. What is that? Malignant tumor, benign tumor, cyst. We cannot abscess, we cannot say using this method, but we can detect this focal abnormality and assess the function of the kidney in this place. On this slide, you can see the real result of the renal scintigraphy along with the renographical curves. You can see the different parameters, calculated glomerular filtration rate for the left kidney, right kidney in total, relative function, uptake of radiopharmaceutical, Tmax, time of T half-life, and you know those indices from the previous part of the lecture. So we can assess the separately renal function, left and right kidney. Here we can see also renographic curve. We can see that it's totally normal. Another example of the normal accumulation in the left and right kidney. This is normal renographic curve, normal high accumulation in the central part of the kidney with decreasement of accumulation of radiopharmaceutical to the periphery. This is totally normal picture. Few words about the hybrid modalities. On this slide, you can see the hybrid device from the General Electrics. We can see the gamma camera, which actually consists of the two crystal detectors with collimators here and here, which can be rotated over the patient's bed. And here we can see computed tomography gantry, and we may perform simultaneously scanning of during the nuclear examination and simultaneously computed tomography. What does it mean? I want you to look at this slide. This is dynamic scintigraphy of the kidney, which shows to us abnormal position of the kidney. This is nephroptosis. It's shown here, lower compared to the opposite kidney. We must admit that there is a lot of anatomical details present on this image, on this scintigraphic image. We can guess only about the contour of the kidneys, about the location of the ureters, of the urinary bladder, and we may assess function of the kidney. So lack of the precise anatomical information. Another example of the TC99M scanning, renal scintigraphy, which allows us to detect urinoma of the kidney here and here to perform differential diagnostic between the malignant tumor, benign tumor, or just leakage of urine. But still we see no lot of anatomical details, just a pointy image which shows us more functional information than anatomical. If we will look at this image, on the left side of the image, we see the computed tomography. We can see abnormal lesion in the region of the left kidney, and a lot of anatomical details, sharp details. We can see vertebrae, musculus psoas, right kidneys, parenchyma. This is pelvis of the right kidney, liver, spleen, pancreas, ribs, diaphragm, urinary bladder. This is the bowel, and gases and feces inside the bowel. So very useful information from anatomical point of view. And on this slide we can see overlap over the computed tomography image of the nuclear scan, which was performed on the hybrid device simultaneously with CT, and we can see no abnormal accumulation within this region, which is an increased accumulation of radiopharmaceutical over the kidney, which allows us differential diagnostics between the lesion. This is not a lesion. This is urinoma of the near the left kidney, proximal to the left kidney. So you can see the example of the hybrid imaging combination of the precise anatomical detailing with the functional imaging of the nuclear scan. This is another example, unresectable endocrine pancreatic carcinoma, transaxial and coronal slices of the fused or hybrid SPECT CT, showing uptake in the abdominal lesion, red arrow, the kidneys, yellow arrow, and spleen. Images obtaining 24 hours after the injection of the yttrium-90 detonate, the total activity 1.7 gigabecquerels. Here we can see another example of the fused image between the computed tomography, which is gray, and colorful functional imaging. Another example of the fusion images, here it's the example of the prostate cancer metastasis in skeleton. We can see abnormal increased accumulation foci in the ribs and clavicles, radioactive urine collection, and atypical renal calyx is visualized. This is anterior view, this is posterior view of the planar scintigraphy, and this is SPECT image shown here. Again, we cannot see a lot of anatomical details. We can see on the level of accumulation of radiopharmaceutical and computed tomography without contrasting. We can see the fusion imaging images below between the single photon emitted tomography and computed tomography, showing us the precise anatomical location of these two lesions in the kidneys. Another more often used variant of the hybrid imaging is the positron emitted computed tomography plus computed tomography, PET-CT, which is performed more often in case of the not urinary tract diseases like lymphoma, like thyroid gland cancer and so on, but sometimes it's also used in case of urinary tract pathology. Here we can see the computed tomography image, sharp details, positron emitted tomography, functional metabolic imaging. Here we can see increased metabolic region of activity and overlap of two images in the coronal plane, in axial plane. This is CT, this is fused images showing us the regions of the increased metabolic activity. This could be the metastasis into lymphatic nodule due to the prostate cancer, for instance, which is actually occurs rare in this region, more often in the pelvis region or abdominal region. Another presentation of the positron emitted computed tomography plus computed tomography, which shows to us the scan with the fluorodeoxyglucose F marked with the phtor-18, which shows to us the lymphoma with a renal involvement. Here we can see increased metabolic activity over the right kidney. This is anterior view, this is posterior view, and this is the diagnosis of lymphoma. Few words about the radionuclide examination in vitro. It means in a glass. You should remember from the previous lessons, actually from the first topic, that we use such an examination called radioimmunoassay, which got its phases. We based it on the reaction antigen-antibody between the level anti-gene and antibody, and this method allows us to very precisely detect different substances in the blood or urine of the patient, usually in blood samples, like hormones, like oncomarkers, and other substances like ferments and so on. And prostate-specific antigen, this is oncomarker for prostate cancer, also can be measured by means of radioimmunoassay, and it will reflect the presence or absence of the prostate cancer. The normal value of the PCA is up to 4 nanograms per milliliter. It's age dependent, and it must be performed in all patients, all persons after the 40-45 years old, annually to early detect prostate cancer. This is another, and probably it's the last slide, the one additional slide about the hybrid modality. This is a very contemporary method of diagnostic, state of the art, combination of the magnetic resonance imaging. These two slides, it's magnetic resonance imaging, and this is positron emitted tomography, which shows, this upper part of the slide shows us a suspicious lesion in the right lobe of the prostate. This is prostate, this is pubic symphysis, these are the pelvis bones, this is a rectum, yeah, and the fat surrounding the prostate. This is peripheral zone of the prostate, this is central zone of the prostate, and transition zone of the prostate. Here we can see the suspicious lesions, which shows to us on the both MRI images here and here. And after the performing F-choline PET, F18 PET, we see the region of increased metabolic activity, which in case of overlap fusion of this image and this image will result in the detection of the prostate cancer, the spread of prostate cancer, which is very useful for the staging and for the puncture biopsy for primary diagnostics. This is example of PET MRI fusion hybrid modality. In the end, I want to show you how the real workspace of the radiologist looks like, because we got 4 monitors here, 3 monitors here, because we must assess, in case of hybrid imaging, the computed tomography, overlap on each slice, fusion imaging with the PET or SPECT imaging, and different slices. So the same slice may look different on different phases of the scanning. So it's very sophisticated method of examination, and this is very useful in contemporary medicine. So this is all. Thank you for the attention.